Picture this. You're hiking. The trail is beautiful, the weather is perfect, and you're feeling extremely good about your decision to spend the weekend outdoors instead of watching television. You're stepping over a log casually, the way people step over logs when they're not paying close enough attention. And then there's a sensation on your ankle that doesn't immediately register as what it is. It's fast. Faster than you expected anything biological to move. A brief, sharp pressure. Two small puncture marks appearing on the skin above your boot. And about 3 feet away, something thick and patterned sliding back into the leaf litter with the unhurried attitude of something that has absolutely nowhere to be and knows it made its point. You look at your ankle. You look at where the snake was. You look at your ankle again, and now the clock is running, whether you know it or not. The next few hours are going to involve a cascade of molecular events inside your body that reads less like biology and more like a carefully orchestrated chemical siege. Your blood, your nerves, your muscle tissue, your cardiovascular system. All of them are about to be introduced to one of the most sophisticated biochemical weapons that evolution has spent hundreds of millions of years engineering. And unlike a lot of things that can hurt you, venom doesn't wait for you to process the situation emotionally before it gets started. So what is actually happening inside your body when a venomous snake bites you? Not the simplified version. Not the your blood gets weird and then you go to a hospital version. The real molecular sequence from the moment those fangs break skin to the point where medical intervention either works or doesn't. Because the actual story is dramatically more complex, more fascinating, and more viscerally uncomfortable than most people realize. Start before the bite, because the delivery system is worth understanding before discussing what gets delivered. Venomous snakes have evolved fang structures that represent some of the most refined biological injection equipment in the natural world. The two primary configurations are solenoglyphus and proteroglyphus, terms that describe where the fangs sit and how they function. Vipers, rattlesnakes, copperheads, the Russell's viper of South Asia, the puff adder of Africa, are solenoglyphus. Their fangs are long, hollow, and hinged at the base of the upper jaw, folding back against the roof of the mouth when not in use. When the snake strikes, those fangs rotate forward to an almost perpendicular angle, plunging into tissue and functioning essentially as hypodermic needles with pressure behind them from muscles squeezing the venom glands. The strike is faster than human visual processing in real time, between 50 and 170 milliseconds in most documented species. You do not see it coming. You experience it as having already happened. Elapids, cobras, mambas, kraits, taipans, sea snakes have shorter fixed front fangs that work through a chewing or pressure mechanism. They don't have the same hinged rotation, but their venom is, in many cases, significantly more potent per unit volume than their viper relatives. A black mamba's fang length doesn't need to impress you. What it delivers does the work. The venom itself is produced in modified salivary glands, a fact that underscores the evolutionary origin of this system from something as mundane as pre-digesting food, and stored in reservoirs connected to the hollow fangs by ducts. The snake has muscular control over how much venom it delivers, which is why so-called dry bites, strikes without venom injection, occur in roughly 20 to 25% of pit viper encounters. The snake is conserving a metabolically expensive resource it doesn't produce overnight, but when it delivers intentionally and with reasonable precision. The injection site in a typical bite from a large viper penetrates through the epidermis and dermis and deposits venom into subcutaneous tissue or, in deep bites, directly into muscle. This matters because the depth of deposition affects how quickly venom enters systemic circulation, and speed of systemic distribution is one of the primary determinants of how quickly symptoms escalate. The moment venom enters your tissue, the molecular chaos begins, and the character of that chaos depends enormously on which snake bit you, because venom composition is not uniform across species or even across populations of the same species. Venom is not a single compound. It is a complex mixture of proteins, enzymes, peptides, and non-protein organic and inorganic components, sometimes containing over 100 distinct molecular species working in combination. Different snake lineages have evolved different venom compositions optimized for their prey, predators, and ecological contexts. A rattlesnake and a cobra are both venomous, but what their venoms do in your body is substantially different. The broad functional categories of venom components are cytotoxic, hemotoxic, and neurotoxic, affecting cells and tissue directly, affecting blood and its functions, and affecting the nervous system, respectively. But these categories overlap considerably, and most venoms contain elements from multiple categories simultaneously. What varies is the dominant effect, the speed of onset, and the molecular targets. Start with hemotoxic venom because pit vipers, the category of snake most people in North America and much of the world are most likely to encounter, lean heavily into this category. Your blood, under normal circumstances, maintains a careful balance between clotting factors that allow wounds to seal and anticoagulant mechanisms that prevent spontaneous clotting in your vessels. This balance is the result of an extraordinarily complex biochemical regulatory system involving dozens of proteins interacting in precise cascades. Viper venom targets this system with what can only be described as malicious precision. Enzymes called phospholipases attack cell membranes. Metalloproteinases break down the structural proteins holding tissue together, creating pathways for venom to spread and causing hemorrhage at the cellular level. Thrombin-like enzymes consume fibrinogen, a critical clotting protein, depleting it from circulation while simultaneously producing fibrin clots that are functionally defective and unable to seal wounds properly. The result is a condition called venom-induced consumptive coagulopathy, where your blood is simultaneously trying to clot everywhere and nowhere, using up clotting factors faster than they can be produced and leaving you in a state where both dangerous clotting and dangerous bleeding are occurring in parallel. Hyaluronidase, present in many venoms, breaks down hyaluronic acid, the ground substance of connective tissue that normally limits the spread of substances through tissue. This enzyme functions as a spreading factor, physically dismantling the tissue architecture that would otherwise contain the venom at the bite site and allowing the entire complex to diffuse more rapidly into surrounding tissue and vasculature. The local effects at the bite site, in a significant viper envenomation, become apparent within minutes and progressively worsen over hours in ways that are difficult to describe without sounding like you're writing for a medical horror anthology. Pain at the bite site is typically immediate and intensifies rapidly. The fang punctures themselves are minor injuries. What produces the escalating pain is the tissue destruction happening in the surrounding area as proteolytic enzymes begin breaking down muscle fibers, connective tissue, and cellular membranes. The term proteolytic means protein destroying, and muscle is largely made of protein. Watching viper envenomation progress locally, which emergency physicians unfortunately sometimes have detailed opportunity to do, involves observing tissue that was functional an hour ago becoming visibly compromised. Swelling begins within minutes and can become severe over hours. This is partly edema from increased vascular permeability. The metalloproteinases have damaged blood vessel walls, allowing fluid to leak into surrounding tissue. And partly the inflammatory response that your immune system launches in response to the foreign proteins flooding the area. The inflammatory response is trying to help. It is doing things that would be appropriate if this were a bacterial infection. Against venom, it contributes to the swelling and pressure that compounds the direct venom effects. Blistering and skin discoloration follow in significant envenomations as tissue at and near the bite site begins dying. Necrosis, cell death, occurs when tissue damage reaches the point where cells cannot maintain function. The discoloration is characteristic, bruising from hemorrhage spreading under the skin, dark patches indicating areas of dead or dying tissue, occasionally the distinctive green or black margins of advancing necrotic change. In severe cases, this necrosis requires surgical debridement, removal of dead tissue, or in extreme situations, amputation. This is what local envenomation looks like. And while it's happening locally, the systemic cascade is running in parallel. Systemically, the hemotoxic effects of significant viper venom begin manifesting within 30 minutes to several hours depending on the amount of venom delivered, the size of the victim, the snake involved, and where on the body the bite occurred. A bite directly into a blood vessel delivers venom to systemic circulation almost immediately. A bite into deep muscle delivers it more slowly. A bite into fatty tissue, which has lower vascularity, delivers it more slowly still. By the way, if you want to go even deeper into the secret lives of ancient humans, I just launched a full course called The Secret Lives of Ancient Humans. 10 modules, 3+ hours of content covering everything we never talk about on YouTube. What they feared, how they communicated, what hunted them, and much more. Plus an exclusive PDF guide included. Link in the description. See you inside. The coagulopathy produces symptoms that range from subtle laboratory abnormalities in mild cases to what physicians call a 20-minute whole blood clotting test failure in severe ones, meaning blood drawn from the patient fails to clot in a glass tube within 20 minutes, indicating clotting factor depletion severe enough to constitute a medical emergency. Bleeding from unusual sites, gums, venipuncture sites from IV placement, spontaneous bruising in areas distant from the bite, indicates systemic coagulopathy. Internal hemorrhage, particularly into the peritoneal cavity or into the brain in severe cases, represents the most dangerous expression of this effect. Cardiovascular effects in severe viper envenomation can include hypotension, blood pressure dropping as vascular permeability increases and fluid shifts from the circulatory system into tissue, and direct cardiac effects from some venom components targeting heart muscle. The cardiovascular system, attempting to compensate for falling blood pressure, increases heart rate. If compensation fails, the patient enters shock, a state where tissues aren't receiving adequate oxygen delivery regardless of what the lungs are doing. Kidney damage is a serious complication in significant envenomation. The kidneys are filtering organs, and when venom proteins, the products of destroyed muscle cells, and the debris of consumed clotting factors flood the circulation, the kidneys face a filtration burden they weren't designed to handle at that concentration and rate. Myoglobin released from destroyed muscle cells is directly toxic to kidney tubular cells. Reduced blood pressure compromises renal perfusion. The combined insult can produce acute kidney injury that, in severe cases, requires dialysis to bridge while the patient recovers. Now step completely aside from hemotoxic venom and examine neurotoxic venom, because it operates through entirely different mechanisms and produces an entirely different, and in some ways more immediately alarming, clinical picture. Elapid snakes, cobras, mambas, kraits, taipans, sea snakes, and their relatives produce venom weighted toward neurotoxic components, though many also contain cytotoxic and some hemotoxic elements. The neurotoxins target the interface between your nervous system and your muscles, the neuromuscular junction, with specificity that represents one of evolution's more elegant and terrifying achievements. Your muscles contract when acetylcholine, a neurotransmitter, is released from nerve terminals and binds to receptors on the muscle cell surface. The binding triggers the membrane events that produce muscle contraction. Normal muscle function then requires the acetylcholine to be cleared, broken down by an enzyme called acetylcholinesterase, so the muscle can relax and be ready for the next signal. Neurotoxic venom components disrupt this system at multiple points. Alpha neurotoxins, present in cobras, many mambas, and other elapids, are small proteins that bind to the acetylcholine receptor with extraordinary affinity and simply block it. Acetylcholine cannot bind. The muscle cannot receive the contraction signal. It stays relaxed. In voluntary muscles, this produces weakness and eventually flaccid paralysis. Muscles that simply stop responding to commands from the nervous system. In the respiratory muscles, the diaphragm and intercostal muscles that move air in and out of your lungs, this paralysis produces respiratory failure. This is the mechanism by which neurotoxic snake envenomation kills without treatment, not blood loss, not cardiovascular collapse from hemorrhage, respiratory failure from muscle paralysis. You remain conscious, cerebral blood flow is maintained, your brain is fine, while your breathing muscles progressively fail. This is not a comfortable way to die, and it's worth sitting with the specificity of that mechanism because it illustrates why antivenom and, in the interim, mechanical ventilation are life-saving interventions rather than comfort measures. Some venoms contain beta neurotoxins that instead target the presynaptic terminal, the nerve side of the junction, and interfere with acetylcholine release. These are typically more difficult to reverse with antivenom because they produce structural damage to the presynaptic terminal rather than simple receptor blockade. Mamba venom adds additional complexity through dendrotoxins, which block potassium channels in neurons and produce hyperexcitability, the opposite of receptor blockade, leading to uncontrolled nerve firing and contributing to the dramatic symptom picture of Mamba envenomation, which can include intense anxiety, sweating, salivation, and cardiovascular effects alongside the paralytic components. The timeline of neurotoxic envenomation is particularly important because it creates a dangerous window of underestimation. In some krait species which produce highly potent presynaptic neurotoxins, the onset of symptoms can be delayed significantly, sometimes 3 to 12 hours, while the venom is establishing its effects at the presynaptic terminal. A person bitten by a krait at night might feel relatively well initially, go to sleep, and develop respiratory failure during sleep when nobody is monitoring. This delayed onset has contributed to deaths in populations where kraits are common because the perceived absence of immediate symptoms creates false reassurance. Cobra bites, particularly from some African and Asian species, can begin producing ptosis, drooping eyelids from the muscles controlling the upper eyelid being affected. Within 30 to 60 minutes, progressing to difficulty swallowing, slurred speech, and limb weakness as the neurotoxic effects spread. The progression from initial ptosis to respiratory compromise can occur within hours in significant envenomations, and the clinical urgency is determined by how fast the respiratory muscles are being affected. The black mamba, the snake most people identify as the world's most dangerous, and not without reason, delivers a venom that combines fast-acting dendrotoxins with alpha neurotoxins in a package delivered via a snake that moves faster than a walking human, can deliver multiple bites in a single encounter, and has enough venom volume per bite to represent a genuine medical catastrophe. Untreated black mamba envenomation has case fatality rates approaching 100% in severe bites. With antivenom and supportive care, survival is achievable. Without them, the timeline from bite to death can be measured in hours. Antivenom is the intervention that changed everything about the human capacity to survive significant snake envenomation, and understanding how it works makes clear why it remains the only truly effective treatment and why the logistics of its production and distribution remain a global health challenge. Antivenom is produced by immunizing large animals, typically horses or sheep. With sublethal doses of venom, harvesting the antibodies their immune systems produce against venom components, purifying those antibodies, and formulating them for intravenous administration. The antibodies bind to venom molecules in the patient's circulation and neutralize them, physically attaching to the toxic protein and rendering it unable to interact with its target receptor or enzyme. The specificity of this process creates a critical limitation. Antivenom produced against one species of snake, venom may be ineffective against another. Geographic variation in venom composition within a single species can even reduce antivenom efficacy if the product was made using venom from a different population. Polyvalent antivenoms, covering multiple species, exist for regions where several dangerous species are present, but polyvalent formulations typically provide less concentrated coverage of any individual species compared to monospecific products. The practical consequence is that effective antivenom treatment requires correct species identification, which requires either the snake being captured or clearly identified, not always possible or advisable, or clinical pattern recognition from symptom presentation. Emergency physicians in regions with multiple venomous snake species develop expertise in matching symptom profiles to likely causative species. But this is imperfect, and treatment decisions are sometimes made with incomplete species information. Antivenom administration isn't without risk. Because it's derived from animal proteins, it can trigger allergic reactions ranging from mild urticaria to severe anaphylaxis in some patients. Serum sickness, a delayed immune reaction to the foreign proteins, can occur days after treatment. Patients receiving antivenom require monitoring and the capacity to manage allergic reactions, which adds complexity to administration in resource-limited settings where much of the global snake envenomation burden falls. The global epidemiology of snakebite is something that sits awkwardly between a major public health crisis and a largely invisible one, depending on which populations you're considering. Approximately 5 million people are bitten by venomous snakes annually worldwide. Of those, roughly 100,000 die, and many hundreds of thousands more suffer permanent disability. Limb loss, chronic renal impairment, disfigurement from tissue necrosis, psychological sequelae from traumatic encounters. The majority of deaths and serious injuries occur in sub-Saharan Africa, South Asia, and Southeast Asia, regions where agricultural workers encounter venomous snakes at high rates, where access to antivenom is inconsistent, where transport to capable medical facilities can take hours or days, and where the snakes present are among the most dangerous on Earth. The Russell's viper of South and Southeast Asia causes an enormous burden of death and disability, with venom that combines potent hemotoxic effects with direct nephrotoxicity and, in some geographic populations, neurotoxic components. The saw-scaled viper of Africa and South Asia kills more people annually than almost any other snake species. The carpet viper, the king cobra, the taipan. These are not abstract threats in their geographic ranges, they are genuine occupational hazards for people working land without protective footwear. The World Health Organization designated snakebite envenomation a neglected tropical disease in 2017, acknowledging the gap between the scale of the problem and the attention and resources directed at it. Antivenom availability in the regions with the highest burden remains inadequate, partly because the economics of antivenom production favor development for markets that can pay for it rather than the populations most in need of it. There are things people do after snake bites that they should absolutely not do, and examining them reveals how persistently wrong the popular mythology around snakebite treatment remains. Cutting the bite site and attempting to suck out venom. This does not work, has never been demonstrated to work, introduces infection risk, and damages tissue that the venom is already compromising. The venom enters tissue and circulation faster than any suction device or oral extraction can retrieve it. Stop doing this. Stop telling people to do this. Applying a tourniquet. For hemotoxic viper bites, this concentrates venom in a limb already experiencing tissue destruction, amplifies local necrosis, and can cause the tourniquet site to become the site of irreversible ischemic damage. The recommendations for tourniquet use in snake envenomation are limited to specific neurotoxic bite scenarios in specific regions, under specific clinical guidance, and even there the evidence base is contested. Electric shock. This was a genuine proposed treatment for a period in the 1980s and was subsequently studied and found to have no benefit. Zero. It doesn't neutralize venom, doesn't reduce symptoms, and adds the specific problem of electrocuting someone who has already had a bad enough day. Ice application causes vasoconstriction that can worsen tissue ischemia in an area already experiencing venom-mediated damage. Do not put ice on a snake bite. Alcohol consumption, sometimes proposed as a folk remedy under the logic that alcohol is a solvent and might neutralize venom. Alcohol is a vasodilator that accelerates systemic venom distribution and impairs the cognitive clarity needed to describe symptoms accurately to medical personnel. This is spectacularly counterproductive. The correct response to suspected significant snake envenomation is to remain calm. Immobilize the bitten limb below heart level to slow venom spread through lymphatic circulation. Remove any constricting items like rings or watches from the bitten extremity. Before swelling makes them impossible to remove, identify the snake if possible without approaching it, and get to a medical facility with antivenom as rapidly as possible while keeping physical exertion minimal. That's it. That's the correct first aid. Everything else is noise. Return to the hiking trail where this started, your ankle. The two small puncture marks, the snake retreating into the undergrowth without so much as an apology, you now know what the clock running means. You know that within the tissue around those puncture marks, enzymes are beginning the work of dismantling the molecular architecture of your cells. You know that somewhere in the subcutaneous space, venom proteins are beginning to move, through tissue planes that hyaluronidase is opening ahead of them like a molecular advance party. You know that your clotting system is about to receive a very unwelcome introduction to thrombin-like enzymes that will consume fibrinogen with complete indifference to the downstream consequences. Or you know that if this wasn't a lapid, different proteins are beginning their journey toward neuromuscular junctions where they will wait, patiently, to block the signal that tells your breathing muscles to breathe. You know that most of the things you were told to do are wrong. You know that the single correct action is to get to medical care with antivenom. You know that panicking and running increases heart rate and lymphatic flow, and accelerates systemic distribution of exactly the thing you want to keep localized. You take a breath. You sit down. You call for help. You keep the ankle below your heart. The snake, somewhere in the leaf litter, has already moved on entirely. It has no concept of what it started. It was following a program written over hundreds of millions of years of evolution, delivering a biochemical message that was never written with you in mind. Your immune system has already started writing a response. Your doctors, when you reach them, will have antivenom written by immunized horses whose antibodies recognize exactly what's in your tissue right now. The biochemical arms race between venom and human medicine has been running for as long as humans have encountered snakes. The good news is that the medical side has never been better equipped to win it. The better news is that you didn't try to suck the venom out.